Hi, I'm Lindsay Bullock, and I'm going to be talking with you about hyperlipidemia, the pathophysiology and management considerations. So first, we're going to talk about lipid metabolism. It is a very complex cycle. So you have your chylomicrons, which is the least dense lipoprotein, and fat from the diet is stored in chylomicrons within the small intestine. And chylomicrons aid in the absorption of dietary fat, and they also transport exogenous lipids from the intestine to the liver and the peripheral cells of the body. Some of the triglyceride, what chylomicrons are mostly made up of, can remain in bodily tissue, such as adipose tissue, or be utilized for energy by muscle cells. What is left of the chylomicron is primarily cholesterol, and this is taken up by the liver. Chemical reactions occur within the liver, and the resulting products are various lipoproteins, which are like your very low density lipoprotein, your low density lipoprotein, and your high density lipoprotein, which is the most dense. Formation of serum lipoproteins occurs by two different pathways. So you have your dietary or your endogenous, and you have your or your exogenous, I'm sorry, and your endogenous, which is the synthesis within the liver. The dietary pathway involves the absorption of fat and cholesterol by intestinal cells. The liver synthesis pathway, or the endogenous, involves the synthesis and secretion of very low density lipoproteins by the liver. These pathways play an important role in the prescribing of medications for hyperlipidemia. So each lipoprotein has specific functions, and this is important whenever you are prescribing these medications for individuals with hyperlipidemia. Your very low density lipoproteins deliver triglycerides, cholesterol esters, and cholesterol esters to peripheral body tissues. Your LDL, your low density lipoproteins, deliver cholesterol to body tissues, and your high density lipoproteins reverse cholesterol transport. They help prevent thrombosis, and they aid in endothelial repair. So what is hyperlipidemia? It is essentially an imbalance of cholesterol within the blood, and the reference ranges I have shown here on the screen to kind of give you an idea of what is normal and what is elevated, what is optimal when looking at where you want your patients to be. So endothelial injury, when looking at atherogenesis, which is the formation of plaques within the blood vessels. Endothelial injury is caused by your risk factors for hyperlipidemia, such as high blood pressure, smoking, hyperlipidemia, the risk of atherosclerosis. So smoking, hypertension, hyperlipidemia. When your low density lipoprotein exceeds 100 milligrams per deciliter, they move through the arterial walls and they embed within the lumen of the artery. And the LDLs oxidize and they're engulfed by macrophages, forming plaques, which are known as fatty streaks. And these plaques consist of what are called foam cells, and these are essentially macrophages that are filled with cholesterol and smooth muscle cells. And as these fill with cholesterol, they can impede the flow of blood through the arteries, and they can become complicated plaques. Complicated plaques can then rupture, and they don't always, but they can. And this can result in a life-threatening health problem for individuals. When you're looking at a patient who has hyperlipidemia, a lot of times there's not any specific physical findings they may look and feel and act normal, or what you would consider normal, but the changes that are going on within their body can lead to symptomatic vascular disease due to the buildup of plaques within the arteries. When you have elevated LDL, your patients can present with things such as arcus corneae, xanthomas, xanthelasma. Elevated triglycerides can present as acute pancreatitis because they can cause that, hepatosplenomegaly, paresthesias, shortness of breath, confusion, and lipemia retinalis, which is kind of like a creamy whitening of the retinal arteries. There are several risk factors for hyperlipidemia, and so these things need to be taken into consideration when assessing patients for hyperlipidemia. So things such as diet, intake of a lot of saturated fats in the diet, physical inactivity, those who don't exercise or who sit a lot, smoking, obesity, certain races and ethnicities, gender, men versus women, genetics, if there's a family history, especially a first-degree relative, that increases the risk, biliary obstruction, chronic kidney disease, diabetes, high blood pressure, and hypothyroidism. Diagnostic findings with hyperlipidemia. So essentially with a fasting lipid profile, when you're looking at all of those lipoproteins on the blood work, like I showed in previous slide with those different levels, you're looking for low HDL or elevated LDL and triglycerides. You also want to assess for things that are risk factors for hyperlipidemia, such as blood pressure and a person's A1C. So you want to look at things not specific to the actual disease process of hyperlipidemia because of those major risk factors. A baseline lipid profile should be obtained early in adulthood. That way the practitioner has an idea of where they stand and they can monitor any changes that occur. They should be done, like follow-up lipid panels should be done on an individual basis, and depending on risk factors and family history, things like that. So there's not really a specific time frame, but as people age, their cardiovascular disease risk increases. So as individuals get older, more frequent testing should be done to monitor that. When you're looking at treatment options, initially with hyperlipidemia, you want to try lifestyle modifications, at least for like a 3-month trial before you move into medication management. A lot of times individuals can change things within their life that can decrease their cholesterol, such as exercising, which is heart healthy, losing weight, making dietary modifications, moving towards a more healthy diet, and decreasing the amount of saturated or trans fats that they're intaking. Smoking cessation has a huge role in hyperlipidemia. The constriction that smoking does to your vessels on top of other factors that are essentially clotting your vessels. So smoking cessation can really, really lessen the effects of hyperlipidemia. And also alcohol consumption, decreasing that. After a 3-month trial, if modifications are not getting these patients to where they need to be in their management, then you may look at starting pharmacologic treatment. And examples of medication classes and medications that you can try are statins, which is typically your cornerstone first treatment option. You also have Zetia. You have bile acid binding resins, fibric acid derivatives, PCSK9 inhibitors, or a combination of various medications. So here I have statins. I have this chart here pulled up, and it shows the different intensities based on risk stratifications and lab levels, a lot of different factors, but showing how much each medication lowers cholesterol levels based on the various dosages of these medications. So the mechanism of action for statins is that they reduce the total cholesterol and LDL by inhibiting 3-hydroxy-3-methylglutaryl coenzyme A reductase. It results in a modest decrease in triglycerides as well as an increase in HDL. And indications for this, of course, are hypercholesterolemia and mixed hyperlipidemia. There are some contraindications, such as liver disease because of how the medication is processed in the body, history of rhabdomyolysis, pregnancy. It's contraindicated in pregnancy. We'll get to a class of medications that is typically used in pregnancy here in just a bit, as well as renal impairment, which also goes back to the way the body processes the medication and excretes it. Side effects typical to statins include mild headache, myalgias, GI upset, and respiratory infections. And just to give you an idea, with statins, you typically get, based on which medication you try, a range of 25 to 63% of a decrease in the LDL. You get a 12 to 43% decrease in your triglycerides and an 8 to 17% decrease in HDL cholesterol. And based on the impact on LDL, I've listed them in order from greatest to least. Rosuvastatin has the greatest impact, then atorvastatin, simvastatin, lovastatin, pravastatin, and fluvastatin. Zetia is another medication that is commonly used a lot of times in conjunction with a statin medication. It acts by blocking the absorption of cholesterol across the intestinal border, and it decreases the hepatic cholesterol stores and increases blood cholesterol clearance. It's, of course, indicated with hyperlipidemia as an adjunct to diet and statin therapy. Contraindications, again, liver disease, and contraindicated in pregnancy and breastfeeding. Side effects common to this medication include upper respiratory infections, diarrhea, arthralgia, myalgia, extremity pain, fatigue, and back pain. And it typically results in approximately a 12% reduction in your LDL. Next is bile acid binding resins. I've listed a couple of examples here, cholesterol and cholestyramine. And these medications work by exchanging chloride ions for bile acids, promoting increased bile acid excretion, thus lowering your LDL. This is one medication or one class of medications that can be used during pregnancy. So that's important to know in treating patients who are pregnant. Contraindications include biliary obstruction, individuals with fat soluble vitamin deficiencies, and individuals with triglycerides that are greater than 300. And that is because this class of medications can actually increase triglycerides. So you don't want to give it to someone whose triglycerides are already very, very elevated, because they can elevate even more. Side effects common to this class of medications include constipation and exacerbation of peptic ulcer disease and hemorrhoids. Another important thing to know about bile acid binding resins is that if they are given with anticoagulants such as warfarin, patients need to be educated on how to take them, because you cannot take them together. You should be taking the anticoagulants at least 1 hour before or 4 hours after taking this class of medications. Another class is fibric acid derivatives. Examples I have listed there: fenofibrate and gemfibrozil. And these medications act by increasing lipolysis of triglycerides via lipoprotein lipase. And though these are used for just hypertriglyceridemia, they also do have a modest effect on LDL and HDL. There's a 50% or more decrease in triglycerides, and also a 15 to 20% decrease in LDL, and a 15 to 25% increase in HDL, and that's due to the reduction of the triglycerides. Contraindications, again, liver disease, gallbladder disease, and severe renal dysfunction. Side effects include abnormal liver enzymes, leg cramps, abdominal pain, and elevated creatinine. Another class of medications are PCSK9 inhibitors, and these are actually injectables that are given subcutaneously. Now, PCSK9 is an enzyme that is made in the liver, and it actually, the enzyme binds to the LDL receptors and essentially destroys them, and that results in an increase in LDL cholesterol. And so this medication acts, they're antibodies that bind free plasma PCSK9, which promotes the degradation of the enzyme that actually destroys the receptors, thus lowering LDL cholesterol. And it actually results in a 50% reduction in LDL cholesterol. So it's very, very effective. Indications: individuals with high lipid levels and extremely elevated cardiovascular risk due to genetic abnormalities. I couldn't find really any contraindications other than hypersensitivity to the medications themselves, or the what they're made up of. Side effects typically are injection site reactions, which are typically mild, and nasopharyngitis. So what you're looking for with therapeutic response in patients with hyperlipidemia, it's very individualized per patient. There's really been a focus more so on the percentage of reduction versus the actual number, like your LDL levels, as well as decreasing the cardiovascular risk. So making those lifestyle modifications. A lot of times, if individuals can modify their lifestyle, doing things such as decreasing their BMI and weight, and decreasing saturated fat in their diet, or stopping smoking, or getting better control of their blood pressure, medications can typically be reduced a lot of times in these individuals. You want to reevaluate a lipid profile after medications are started. You want to do this about 6 to 8 weeks after initiation to see if it is effective. And also you want to, any change in medications, you want to reevaluate 6 to 8 weeks after those changes. After a year of treatment, you can move to, as long as the patient is responding well to the therapy that they are currently on, they can be decreased to reevaluation every 4 to 6 months. Patient education is very, very important, especially because of the cardiovascular risk. Decreasing cardiovascular risk by telling patients to exercise, giving them ideas for things they can do to exercise, whether it be just walking or doing more high intensity exercise, depending on what their level of ability is. Helping them find the right smoking cessation method, as long as they're motivated to do so. Even just telling them to try and decrease the amount they smoke, though that won't take away their risk 100%, it's small steps towards a goal. You also want to talk with them about medication adherence. So making sure that they're aware of side effects that they can have, so they don't experience those and stop the treatment because they don't like the way it makes them feel. Also, with the side effects, if they're experiencing something that they can't tolerate, then there's always other options for medications that can be trialed to see what works best for them. Also talking with them about the reason for treatment. Cardiovascular disease is the #1 cause of death in the United States. Letting them know how real this is and how much their cholesterol levels affect their overall health and well-being and quality of life. Also the cost of medications, that also is plays a large part in people sticking to their treatment regimens. If they can't afford it, a lot of times they might not want to admit that they can't afford them, and so they stop taking the medication and don't inform you that they're having problems buying their medications. There's a lot of generic medications that are lower cost that can be prescribed. So talking with them about those things, and also with the lifestyle modifications, if they're having issues with anything such as their diet or exercise, referrals can be made to help them find what works best for them. Patient considerations. Like I said, it's very individualized. You want to make sure that you're looking at the whole patient. You want to talk with them about their socioeconomic status, the cost of their medications, what affects their condition, as well as their other comorbidities are having on their mental health. You want to make sure that they are healthy and well and have a positive mindset on their treatment regimen, so you can see improvements in their cholesterol levels. There are cultural considerations, especially in African Americans, Hispanics, Native Americans, and Asians. With African Americans, they just have an overall higher prevalence of high blood pressure, obesity, smoking, kidney disease. And so addressing these patients very aggressively and getting them started on medications early on, and addressing their lifestyle and their diet and all of those factors can really help get on top of treating these patients for hyperlipidemia. Hispanics, there's actually been 2 general haplotypes found that affect lipid processing in Hispanic Americans, and it increases their risk for more elevated lipid levels. So knowing things like this can make you as a practitioner more aware of what to look for when you have a Hispanic American patient come in and you're screening them for hyperlipidemia. Native Americans, it's actually been found that their cardiovascular deaths are increasing. I have seen where they have high rates of diabetes, which has a huge impact on cardiovascular health. So making sure that there's good education and follow-up on comorbidities in this population can really help get a grasp on their cardiovascular health. And Asians, there's a very high prevalence of coronary disease at a younger age in these individuals with the absence of any risk factors that I've discussed. So essentially you look at these patients and you would think that they should be healthy, but they really have serious cardiovascular risks occurring. So we need to make sure that we are addressing these. Comorbidities, like I've mentioned many times already, affect cardiovascular health and affect high cholesterol levels, diabetes. Whenever you have patients come in who are shown to be pre-diabetic, you need to make sure that we're getting on these patients with lifestyle modifications and making sure they're getting out and doing some kind of exercise and watching what they eat and making healthier choices. Metabolic syndrome, hypothyroidism, making sure that this is picked up on and diagnosed, because if left untreated, it has a huge effect on cholesterol. High blood pressure, you need to aggressively treat patients with high blood pressure along with their hyperlipidemia to make sure that their heart stays healthy. And chronic kidney disease, their statins can be used on these individuals until they start receiving dialysis, and then you have to switch medication therapy. So keeping up with these patients and where they are in their kidney disease and their kidney function is very, very important. Also, talking about cultural considerations, dietary habits, and cultural beliefs, making sure that you're talking with these patients to find out what their cultural beliefs are, and trying to not steer them away from their typical dietary practices, just helping them find better options within their cultural dietary habits that would be more healthy for them. Maybe referring them to a specialist, like a nutritionist or a dietitian, may be helpful for these patients. All right, thank you so very much.